the way from Muchinga province. I can also see we have Chipo Shampande from Chongwe, Francesca Esnat Nyambe from UTH. Francis Mupeta has joined us. Thank you so much. We are welcome. We also have Kabwe General Hospital, Walubita, Malilwe. You are all welcome to today's echo session. And we are having a very interesting topic, which we'll get into shortly. All right. Thank you so much, everyone, for joining the call today. We have 109 participants so far, and I think in the interest of time, by my watch, the time now is 14:30, and I'd like to welcome you to today's echo session, where we're going to be looking at a very interesting topic on TB. But before we get into today's subject, allow me just to remind everyone that this week, we are commemorating World TB Day, which falls on the 24th of March. And this is an annual event where we commemorate TB. The theme for this year is Invest to End TB, Save Lives. So it's actually very good that on the ECHO platform today, we're going to be discussing TB and how healthcare workers can be involved in the fight against tuberculosis. We have a very special didactic presenter today, who's a subject matter expert on TB and one of few TB experts in the country, and she will introduce herself when the time comes. But before we get to the didactic presentation, allow me to also acknowledge the presence of the subject matter experts that we have for today's session. Just check, Dr. Linos Mwinga, are you on the call? Yes, I can see Dr. Mwinga has joined the call.
Good afternoon. Good afternoon, I'm on the call.
Thank you so much, Dr. Mwinga. And I would also like to welcome Dr. Lisulo. Are you on the call? All right, Dr. Lisulo will join us as the meeting goes on. And maybe much later we'll get Dr. Kasese joining us as well as a subject matter experts. So without further ado, allow me to move on to welcome the didactic presenter for today, who's going to take us through active case finding. I'll ask her to introduce herself and tell us what her role is in the TB arena, and to dive straight into the didactic presentation. Dr. Muyoyeta.
Thank you, Dr. Singini. Good afternoon, everyone. I hope you can hear me clearly. May I get confirmation?
Yes, we can. Thank you so much.
All right. As introduced, my name is Monde Muyoyeta. I'm a medical doctor, infectious diseases epidemiologist. I am director TB programs at CIDAS. I also serve as clinical trials unit leader at CIDAS. I have been working in TB and around the TB subject for the last 17 years. Thank you very much.
Thank you so much, Dr. Muyoyeta. So maybe I'd like to ask if you'll be sharing the slides from your end.
Yes, I will share the slides. If permitted, I'll go ahead and start my presentation.
Thank you so much. You may go ahead with the session for the day. Thanks. So dear network, as Dr. Muyoyeta is sharing the screen, later on we're going to have a case from Western Province, particularly Yeta District Hospital in Sesheke, and they're going to take us through a discussion on how they have managed a TB case from that district. So look forward to that discussion. Over to the didactic presenter.
Thank you. Sorry, just moving something out of the way. Right, so as introduced, my presentation today will talk about active case finding. I think it's going to be a quick and straightforward discussion. I'm pretty sure that we've had this presentation before, or we've had some discussion around active case finding in the past. So briefly, to just point out what the learning objectives are for this presentation today, we will define global TB epidemiology and the Zambia TB epidemic. We will describe or discuss why active case finding is a priority. We will define what active case finding is, and then we will go on to distinguish active case finding from passive case finding. And then we will highlight strategies to enhance active case finding. I would also like to state that I have no conflicts of interest to disclose. At this stage, I think we'll pause and go to the poll question before we proceed.
Thank you so much. So the first poll question says, of the estimated 10 million global incident TB cases in 2020, 5.8 million TB cases were diagnosed and reported by the national systems. True or false? I'll repeat that. Of the estimated 10 million global incident TB cases in 2020, 5.8 million TB cases were diagnosed and reported by national systems. Is the answer true or is it false? Have your say. Would like to get feedback from everyone on the call so that we assess how much we know about the epidemiology of TB at global stance. So we have approximately 212 connections in today's meeting, and so far only 35% have polled. Just give it a few seconds so that we have everyone take part in the poll. I note that people from Litambia in Senanga have not polled yet. We're waiting for you to poll. All right, just a few seconds to go and I will end the poll and show the results so that Dr. Muyoyeta, you can see the voting pattern. So dear network and Dr. Muyoyeta, you note that of the participants who have polled, 83% think true is the correct answer, and we have 17% that think B is the correct answer. So I'll stop sharing the results and hand over to the didactic presenter.
I can still see the poll running. Can I continue with my presentation?
Yes, please go ahead.
Okay. Right. So most of you had the response correct. So in terms of 2020, there to the left, we see the map showing the TB, estimated TB incidence in 2020. And just to mention that the darker the blue shading is, the higher the incidence of TB. And what you see there is that Sub-Saharan Africa seems to have the highest incidence of TB. It's important to note that around an estimated 25% of the global population is latently infected with TB. And it is estimated that 10% of those go on to develop active tuberculosis. Right. And the poll question there, 10 million incident cases, only 5.8 million were diagnosed and reported. We can all calculate there. This is really telling us that an estimated 40% of all persons that developed TB in 2020 were not diagnosed. We all know that tuberculosis is a respiratory disease and it's transmitted. It's an airborne disease. Therefore, for any case that goes undiagnosed, that means that person goes on to infect other people. It was estimated in the same year that 1.5 million people died from TB, and that TB is the second leading infectious killer disease, surpassed only by COVID-19. It's also important to note that there are 30 high burden countries, and that these countries accounted for 86% of the new cases. So you can make a calculation there of how many countries we have globally, and you see that only a small number of countries are contributing to the burden of TB, to the bulk of the burden of TB, and we will see which countries those are in a few slides later. Also of importance to note is we do have a problem with drug-resistant tuberculosis, and there we have even a bigger problem in terms of diagnosing and putting people with drug-resistant tuberculosis on treatment. And in 2020, only an estimated 1/3 of all people who have drug-resistant TB received treatment. The last bullet point there really pointing to the cost of treating tuberculosis. This year, it was estimated that $13 billion would be needed annually for TB prevention, diagnosis, and treatment to achieve the global targets that have been set. What about Zambia? So this is the latest infographic that we have for Zambia 2019, but this data hasn't changed much in 2020, except I want to mention here that in 2020, we notified 40,000 individuals with TB and not 36,000 individuals. However, the estimated number of TB people that fell ill from TB is 59,000. This number still stands in 2020 and 2022. And in 2019, we only notified 36,000. In 2020, we notified 40,000. We can calculate the number of people that are missed, In 2019, 23,000 people were missed. So meaning these people continue to spread tuberculosis, but apart from spreading tuberculosis, these people are also at risk of adverse outcomes or poor outcomes, which include death. In terms of death, it was estimated that 15,000 people died from TB, and of note there is that quite a big proportion of those that died were people living with HIV. Colleagues and audience, I think we should acknowledge here, tuberculosis has been around for a long time. It is a preventable disease. It is curable. There really should be no excuse why we continue to see high death from tuberculosis, or why tuberculosis is the second leading cause of death among infectious diseases. In terms of mortality, hope you can see my slide there to the right side. What we see is that we are not impacting much on mortality. We had a huge drop between 2000 and 2005, where we had a significant drop in mortality. After that, we seem not to be making much of an impact in people who are HIV uninfected. Okay, so we need to do more to prevent this death from TB. So now we look at the global list of high burden countries for TB, HIV-associated TB, and drug-resistant tuberculosis. And this list is the one that's in use between 2021 and 2025. And we see Zambia there. I won't spend too much time on this slide, but we see Zambia there, and it's at the confluence of TB HIV, so meaning we are a high burden country for TB HIV. We are also in the group of high burden country for drug-resistant tuberculosis, and of course for TB on its own. So what evidence is there that we are missing TB cases? There is a lot of evidence, and I just picked 3 examples. There are many other examples, even from our daily practice, that I would call anecdotal evidence. However, I picked up these 3 publications. The top one there, very recent publication, published just this month, a few days ago, Incidental Tuberculosis in Sudden, Unexpected and Violent Death in the Community in Lusaka, Zambia. So I would urge all of you to read this, to find this paper and read it. Very interesting findings in this paper, where they found quite significant number of people that died, some from violent death, others, found dead, and brought in dead, and these are considered homicide cases which have to undergo postmortem. And TB was found in a significant number. I think if I remember correctly, around 8% of these individuals actually had tuberculosis. So, and it was an incidental finding because some of these people died from violent death, others death unknown cause, found dead, but in fact we could conclude that the cause of death could be tuberculosis. The 2 other studies that I'm showing there, both are postmortem studies that were done in UTH here in Zambia, one in 2015 and the other one in 2016. Both these studies again showed that a number of people that died in hospital, these postmortems were done in hospitalized patients that died but had a diagnosis of a respiratory disease other than tuberculosis. In these 2 studies, again, it was found that quite a significant number of children and adults in UTH who died from a respiratory condition had tuberculosis, but had not been diagnosed prior to death, but was diagnosed at postmortem. So really showing that we are missing these cases of TB. At this stage, we pause and go to the second poll question. Over to you, Dr. Singini.
Thank you so much, Dr. Muyoyeta. The second poll question reads, passive case finding waits for the patient to volunteer classical symptoms of tuberculosis when they present to the health facility. I'll repeat that. Passive case finding awaits for the patient to volunteer classical symptoms of tuberculosis when they present to the health facility. Is the answer true or is it false? So there we have it, network. Very simple question regarding tuberculosis, active and passive case finding. So we'd like to hear your thoughts. So the network, currently we have 319 connections and would like to see more than 200 people or at least 300 people participate in this poll. You agree with me that it's not a very difficult question, but it would be interesting to know what the results will be. And I'm sure, Dr. Muyoyeta, you can see already how the voting pattern is going, and I hope the subsequent slides will be able to address the answer to this question. So in a few seconds, I will be ending the poll and sharing the results. We have 144 people that have polled so far. All right. In the interest of time, I'll end the poll and share the results with you, network, so that we can see how the voting pattern was regarding this particular poll. So there we have it. You can see that 73% of the people that polled think A, which is true, is the correct answer, and 27% thought B, false, was the correct answer. Dr. Muyoyeta, please impart some knowledge.
Thank you, Dr. Singini. Very interesting there. This was a giveaway question. So I see that the majority of the persons, of the participants got the question right. So we'll go on with our presentation. And we'll learn about the differences between passive case finding and active case finding in a minute. However, the next part of our discussion is really looking at why and how we are missing these TB patients. I think this is very important for us as practitioners in the field to understand this. This discussion is very, very key to active case finding. So this is an onion ring presentation. Basically, I will try and outline what it is. So the outermost, and I hope you can see where I'm pointing, the outermost ring there is basically telling us about cases of TB out there that do not have. So we think of a country like Zambia, we think of Zambia, and we have an estimated 59,000 TB patients. In all those people that are incident TB cases, we have groups of people that have no access to health services. And I'm sure we have people from right across the country, and you will agree with me that Zambia is such a vast country, and there are people who have to travel long, long distances, cross rivers to get to a health facility. And sometimes when they get to that health facility, it may be a health post without a qualified medical practitioner. So that's one group that has no access to health services. And so they are missed. We will miss them. We will not diagnose them with TB. The second ring there, number 5, if you like, denoted number 5, these are cases are patients or people who have access to health services, but they do not go to health facilities for whatever reason. This group of people, we usually talk about health care seeking behavior. There are various reasons why people would choose not to go to a health facility or to the health services, even when they feel unwell. Okay, and these reasons, some is to do with the gender of the persons. For example, with male, we talk about emasculization and feeling they cannot admit that they're not feeling well, and therefore, going to a hospital is a sign of weakness. Others, it could be just maybe the stigma. They could actually know that the symptoms that I have, I've heard about this could be TB, or, and the fear of the stigmatization that accompanies TB may stop somebody from seeking health services. So that's another group of people that we miss. In terms of the healthcare seeking behavior, so far the examples I've given are individual health barriers, individual barriers to accessing health, but it's also important here that we understand that there are also what we refer to as health services barriers. And there are multiple things that fit into the definition of a health service barrier. So for example, a simple example I can give is overcrowding at the health services and long queuing at times. That alone may be the reason that a person decides you know what, I feel unwell, but I'm not going to go. Because, you know, if I go, I'm going to be in that queue for 5 hours. I don't have time for that. So these are missed patients who often, if they come, will come very late and will likely have a poor outcome. Then we have the third outer ring there, which these are our patients who actually come to the health facilities, but we do not diagnose them. And we do know from evidence and from many years of working in the TB realm that a huge chunk of our TB patients are actually missed within the health facility. And the main thing that contributes to that is the low index of suspicion and also the passive case finding that we just asked about. Often as practitioners, we wait for the patient to volunteer classical symptoms of tuberculosis, okay? Classical symptoms of tuberculosis, which would be, you know, prolonged cough, unintentional weight loss, you know, fever, night sweats. And we may have a patient who presents to us with a cough and they may report and say, no, it's not a very prolonged cough. We don't probe. And because we feel it's not a classical presentation, we may not then investigate that person for tuberculosis. The fourth ring there from the fourth ring there, number 3, is those patients that we diagnose within the public and the private sector, but we do not report them. This is a big issue. I think some of you may be aware about the data quality audit results that the National TB Program disseminated. I think that was last year or 2020. But basically, the National TB Program undertook a data quality audit, quite comprehensive and quite representative of our health services and systems here. And that report or that work actually did show that we are underreporting. Basically, we find TB patients, we start them on TB treatment, but we do not report them to the national notification system. And therefore, if they are not reported or notified, they are counted as a missed case. Moving on, moving on, number 2, we also have cases that are diagnosed by the National Tuberculosis Program or providers, but these are not recorded or reported. So not recorded and not reported. So it's very similar to number 3 there. Sorry. And then you see now the last point there is the cases that are recorded in our tuberculosis notification system. So you see really a small proportion finally. So if you think of the case of Zambia, 59,000 estimated TB patients. And for all these reasons, in the end, we notify around 60, 61% or 62% of all our TB patients. So it's very important to be aware of the reasons why we have missed TB patients. Right, moving on. Now we zero in and talk about active case finding. So what is active case finding and what is passive case finding? I've already alluded to what passive case finding is. We wait for the patient to present at the facility, usually to the TB department, and then we wait for the patient to self-report classical symptoms of tuberculosis. This allows for many cases of TB to be missed both in the community and at facility level. As opposed to active case finding, to passive case finding, active case finding actively seeks to find undetected cases of TB. Right. In other words, I like to say the provider initiates screening for TB by asking about symptoms of TB and contact history. So I like to give examples of how this can be done. Colleagues, we know that TB is a chronic, tends to take a chronic course and has an insidious onset. Slow progression basically is what I mean. So some of the patients that we have that come to our health facilities, they will maybe have had symptoms of TB over several weeks, but the reason they came to the health facility on a specific day is because they have an acute problem, which may not be related to TB. They have come today because they have developed diarrhea, which started yesterday. Because that's bothering them a lot more than the mild symptoms or slow symptoms they've had of TB, they will not report those other symptoms. They will report what has brought them to the health facility today. And all they will tell you as a health provider is that I'm here today because I've got abdominal pains and I developed diarrhea and I had several loose stools, and that's why I've come. Active case finding means that when you have a patient like that in front of you, yes, you deal with their acute problem that they've come with, but history taking is very important. And at this stage, you then ask, yes, I have noted that you have diarrhea, which started yesterday, and you have severe abdominal cramps. However, I would like to find out how your health has been in the past few weeks or several months. Have you been coughing? Have you noticed that you have lost weight without intending to lose weight? Do you feel, do you have fever or do you feel cold? I think fever in our setting, commonly we like to say, do you feel malaria-ish? Are you sweating a lot at night such that where you're sleeping is wet? Believe you me, we are in a high burden country. If we all did that and asked those questions, it will go a long way in finding the missed TB patients. Right. We must note that active case finding can be done both at facility or at community levels, and it involves many, many activities, which we will discuss when we move on to discuss how we enhance active case finding. We pause and we move on to the third poll question. Dr. Singini, over to you.
Thank you so much, Dr. Muyoyeta. Also, as we are getting into the last 10 minutes of the presentation, the third poll question says, workforce development is one of the activities undertaken to enhance active case finding. I'll repeat that. Workforce development is one of the activities undertaken to enhance active case finding. I must say, Dr. Muyoyeta today has given us some very, very, very interesting questions, which are giveaways in the most part. But then let's see what the network thinks. All right, so we have a good number of people that are taking part in the poll. Right now, we are hovering slightly over 63 people that have taken part in the poll. I invite the rest of the network to just cast your thoughts through a poll, and then we will get back to the didactic presentation. So far, you will agree with me that most of what we have discussed so far seems quite easy to fathom, and is something that can be easily understood and implemented at facility level. So getting back to the polls, we have close to 200 people that have polled, and in the interest of time, I will end the poll and share the results. So we have almost a landslide polling where we have 98% of the network siding or leaning towards option A, which says true as a correct answer. And only 2% thought B was a correct answer. For some reason, I'm unable to display the results, but we have the majority of the participants going for A as the correct answer. Dr. Muyoyeta, over to you. Right. So I'll just stop sharing the results and then hand over to Dr. Muyoyeta to take us through the subsequent slides.
Thank you, David. So yes, landslide there, almost 98% got it correct. And this was a leakage, actually. The previous slide had the response. So for the few of you that missed it, maybe you didn't pay attention to the slide just before the poll. So moving on. Evidence, and I do recognize that I'm repeating myself a little bit here, but I think it's important so that, you know, we go away with a very, very clear understanding of what we need to do in terms of active case finding and increasing TB case detection. So evidence shows that people with TB present to the health facilities, and yet these people are not identified. Okay. So active case finding is usually a package of different interventions, and it requires appropriate planning and preparation. Okay, we must note also that active case finding strategies may also involve the strengthening of existing passive case finding services, and I think I've already alluded to this. So how do we enhance active case finding at facility level? You see there, the first point is workforce development. What do we mean? Yes, we are healthcare providers. Yes, we are trained to see patients, to examine patients, to take a good history and all that. But sometimes we do need to remind ourselves. And so we do recommend that to enhance active case finding for TB, we need to do a reorientation of staff on TB diagnosis to raise the index of suspicion, okay? So when we raise the index of suspicion, basically what we are saying is that we limit or minimize the risk of missing a person who may have TB who may be presenting to us. We also implement performance monitoring tools to assess workforce performance. Also to assess any challenges there might be, or indeed even needs. So yes, we may come to a facility and say you need to start doing active case finding, and we do the orientations and everything, and we go away without putting in a monitoring tool. We will not know that a facility is failing to perform because maybe simply we didn't plan to have enough diagnostic tools, so enough cartridges, for example. So you know, the lab is suddenly receiving more samples than they have previously received, and suddenly run out of cartridges if they're using expert as an example. So it is the monitoring of the performance that will help us pinpoint what the challenges might be, especially for facilities that do not improve the performance once you've enhanced their capability to do active case finding. Then the screening of attendees. We need to make sure we are using the appropriate screening tool for screening everyone who's attending the health facility. Okay, we also recommend establishing fast-track screening services for TB. This particular one I like, I've used a lot in the work that I've been doing around TB. So basically what we mean is setting up a point within the facility, preferably in a place that's quite open, that people can easily see. It helps also to destigmatize TB so that patients can actually go directly to that fast-track place to be screened. Or indeed, even clinicians can refer patients that they're identifying as needing TB evaluation. They can refer them to the fast-track screening service. The fast-track screening service must be a full package. It must have all the required documentation present there, including all the national TB registers present there. If possible, there must be a clinician there to screen these patients, because remember, it's not just TB. Much as we are looking for TB, these patients must still be assessed fully so that in case, if it's not TB, they are treated appropriately, or indeed, even if it's TB, they might have other problems, so they need to receive the appropriate treatment. It's also important to strengthen the cough triage. So cough triage, we commonly, it's a package, it's part of the infection prevention package or protocols, where patients in a high burden setting like ours, we have what we call cough identifiers, or you put information around to say any person who's coughing must be quickly moved out, but sent to somebody who will quickly screen them and move them out of the health facility, so that we minimize the risk of infecting others who are waiting to be seen. And then we must also strengthen TB screening in at-risk group, high-risk groups. So for example, people living with HIV. Fellow practitioners, I think for those of you who are working in HIV clinics, I think you know that the current guideline is that a person living with HIV must be screened for TB at every contact with the health services. I hope we do that. Other at-risk groups, for example, children with undernutrition. So in our nutrition clinics, we must screen. Basically, and even in MCH, we live in a high TB burden country. So children below the age of 5 years are also considered high-risk patients. We must ensure that we have IEC materials. We must be raising awareness. So some of the things that we've done in some of the health facilities that have been very successful is we actually have treatment supporters or peers who do rounds of sensitization in the facility throughout the day. Every 2 hours is what we recommend. If there isn't enough staff, even every 3 to 4 hours, to ensure that all those patients and even those who've accompanied patients, whilst they are waiting, they hear about TB, and therefore we basically create demand. They may then, recognize that, oh, actually I might have symptoms of TB, and let me go to a fast-track service for screening, or indeed even mention to the provider who's seen them that they suspect they may have tuberculosis. So moving on, this is just an example. This is the current screening tool that's in use. I don't know if you have it. If you don't have it, it's important to have this. It helps. It's really like a checklist that helps you identify which patients should be fully evaluated for tuberculosis. Moving on, still discussing enhancing active case finding. It's very important that even as we improve the way we evaluate our patients, that we have our recording and reporting tools in place. Because if we do not record accurately, the information and the data when we reviewed will give an impression that there's no improvement at a specific health facility. We must improve diagnosis. So here, what are we talking about? We know now that we have expanded access to expert, which is good. So that's improved diagnostic capacity and accuracy. Where we don't have expert, as much as possible, we should work at improving logistics for transporting or couriering sputum samples to the next expert site that can then test these samples, as expert is the preferred diagnostic test. I have already spoken about sensitization and awareness raising, and this is key to be done in all departments of the facility. Okay, So very, very important, this slide. A lot of us think that TB screening should only be done in OPD or outpatient department, but actually no, because we are such a high burden country. Colleagues, you've seen from the earlier slides where I spoke about postmortem studies in UTH that showed that people with admitted with respiratory diseases where a significant number were found to have tuberculosis, which was missed, and this was found at postmortem. So screening for TB in active case finding must happen in all departments in the health facility. Here we've listed inpatients, OPD, MCH, ART, but we must extend it even to our surgical wards. We must extend it to the undernutrition clinics as some examples of where we must do enhanced screening for TB. We pause here and go to the next poll question, and I think this is the last one. Dr. Singini, over to you.
Thank you, Dr. Muyoyeta. Right. We have two poll questions in succession. Poll question number 4, I'll just read through them, and then we go to the last few slides of the didactic presentation because we have just about a minute or two to sum up the presentation. So the 4th question says, what should be prioritized when doing active case finding? What should be prioritized when doing active case finding? Is it A, facility-based active case finding, B, community-based active case finding, and C, both of the above? So that is poll question number 4. And I'm equally struggling to launch the poll, but I will transition to the next poll question, which was saying, poll question number 5 was saying community TB screening should be targeted. Is it true or is it false? I'll repeat that question. Community TB screening should be targeted. Is it true or is it false? So in the interest of time, dear network, I'm going to quickly ask Dr. Muyoyeta to take us through the last few slides, which will speak to some of these questions, and then we'll discuss on the other side. Over. Right. Dr. Muyoyeta, you may carry on. We are
yes, sorry, I was muted. So here's the answer to the last poll question. When we do community active case finding, it must be targeted, and this is highly recommended. So what do we mean when we say targeted? Basically, we mean it must be targeted at the most high-risk persons or people or population. So at the moment, mostly it is recommended that we target household contact tracing, or we do household contact tracing as community-based active case finding. It has high yield as opposed to open community case finding, for example, just setting up at a market or at a bus stop and all that. That has very low yield and is very, very expensive to do and ends up wasting, scarce resources that we have. It is very important that we do awareness raising and demand creation when we are doing community based active case finding. So in conclusion, TB screening must be done in all departments. Everyone must be involved in TB screening. So all cadres of health professionals, a full workout of TB patients ends with contact tracing. Remember, when we have diagnosed somebody with TB, we must proceed to do contact tracing. we must remember that good preparation is cardinal for success, and that all TB patients, including those who have died, must be notified and an outcome must be determined and recorded. This, I believe, is my last slide. Thank you. Over to you, Dr. Singini.
Thank you so much, Dr. Muyoyeta, for really simplifying how TB can be easily diagnosed and how you have emphasized that everyone in the health sphere has a role to play in diagnosing TB. I like saying that even front office can be involved in diagnosing TB for those that are working in private facilities. So at this juncture, we'll quickly have a brief discussion, probably in 5 minutes or less, or if there are any questions from any members of the network to ask Dr. Muyoyeta and the other subject matter experts on the call. We have Dr. Mwinga, and I think I can see Dr. Mupeta has joined us. Thank you so much. So there's a hand from Samuel Mwabafu as Team Yeta is preparing for their case. Samuel, please go ahead and ask a question or contribution.
Yes, good afternoon.
Afternoon.
Yes, Dr. Muyoyeta, good afternoon, and thank you so much for that wonderful presentation. I've followed you, though I just joined somewhere in the middle. I just want to maybe echo a few sentiments with regards to the misdiagnosis of some TB cases. What we have noticed, I think, from the laboratory point of view, especially when we do what is called the TSS, or maybe let me introduce myself. My name is Samuel Mwabafu. I'm based at the National TB Reference Lab here in Zambia, maybe for those who don't know me. Yes, so Doc, what we have noticed when we are doing the TSS, the technical support services with regards to TB, what we have noticed is that what has been causing a lot of misdiagnosis, I think it is the quality of the sputum that is reaching the lab, the quality of the specimen. What we have noticed is that in most cases, when there is the mass screening and so on, the quality of the sputum that reaches the laboratory, in most cases, it is of suboptimal quality. In most cases, it is salivary. And as a result, maybe that can be attributed to the misdiagnosis, something like that. So when it comes to a reorientation of the TB, maybe personnel in the detection of TB is a good thing. But I think what we have seen in most cases when we collect data, the quality of the sputum that is reaching the lab in most cases is not of good quality. So I don't know how that can be addressed to ensure that this misdiagnosis can be minimized to some extent. That was my concern. Thank you so much.
Thank you so much, Samuel Mwabafu, for that valuable contribution. And indeed, it's very timely as we are talking about enhancing case detection. I see another hand from Dr. Chalwe from Kawe Women and Newborn Hospital. Please go ahead with your comment or contribution. And then we'll have a brief response from Dr. Muyoyeta, and then we'll get into the case afterwards. Dr. Chalwe, please unmute yourself and give us your comment or question. Right. Dr. Chalwe may be struggling to unmute, but then in the interest of time, okay, please try again, Dr. Chalwe. Please try to unmute.
Thank you very much, Dr. Singini. I was trying, it was not allowing me to. So mine is more of a contribution. I think one of the things, I'm Dr. Chalwe, by the way, from Kabwe. Thank you very much for the presentation. One of the things I think would also help us in terms of active case finding for TB is, yes, the issue of having a TB corner has been very important for our facilities, but I think that also creates a gap between people working in the TB corner and the clinicians. So I think looking at intensifying, the workmanship between the two would actually be very important. For clinicians, we tend to neglect some of these questions that would be important in finding cases that are actually missed at some point. So I think one of the emphasis we should put is when you talk about TB, it's not just for the people in the TB corners who are working from there. So I think it would be important for people that are actually working in the TB corners to re-emphasize the importance of clinicians screening for TB in their OPDs, in their research centers and all that. I think that's my observation. Thank you.
Thank you so much, Dr. Chalo. And what you have said is quite accurate, where we have seen even medical doctors declining to attend to patients, or rather starting treatment in some patients, saying, I'd rather someone from chest clinic does it. And you have clinical staff sending consultation to chest clinic for a patient to be seen while ward rounds are being done, when something that everyone can actually take part in. And then you involve the chest clinic when it comes to reporting and recording tools. So like was highly emphasized, everyone needs to get involved. Perhaps I'll ask Dr. Mwinga to respond to the concern from Mwabafu regarding the quality of sputum. Team Yeta, please start sharing your screen so that we get into it just after Dr. Mwinga's comment.
Thank you, Chair. Yeah, true to that, from some site visits that we've done, yes, the laboratory people have always had that complaint of the quality of the sputum that is being sent there. That would actually maybe be compromising on the yield that is being gotten ultimately. So I think the onus still goes back to us at facility level, district level, provincial level, to make sure that there's that training and orientation of all health providers on indeed how to induce or how to indeed collect a good quality sputum sample. And of course, there is an SOP to that effect that should actually be followed through on how a good sample should be collected. For those that cannot readily expectorate, you know, there is that issue of someone taking the deep breaths in and coughing deeply from deep inside into container to ensure that we get a sputum, good quality sputum sample. So I think it's about the training at facility level that needs re-emphasized on how to collect the sample. And here, the lab people should actually work closely with the people on the clinical end, patients, to ensure that that is actually engraved and everyone is actually aware of the quality of a sample that should actually be taken and they end up at the lab. Thanks.
Thank you so much, Dr. Mwinga. In the interest of time, allow me to invite Jackson Mwewa to take us through the case presentation. Then we'll have a discussion and we'll still get back to some of these questions and concerns that have been raised so far. Jackson?
Good afternoon, everyone.
Afternoon.
This is Jackson Mwewa from Yeta Hospital, Pediatric Center of Excellence, presenting the case.
Thank you so much, Jackson. Yeah, you may go ahead with the case presentation.
Okay, so this is the patient was reviewed. There is a NS female 1 year 2 months, presented to Yeta Hospital on the 2nd of March 2020 with 3-day history of diarrhea, fever, irritability, cough, and difficulty in breathing. Background: I was dread milestone not since birth, to 5 months ago. No non-TB contacts, no history of having visited a local clinic several times with respiratory symptom over 5 months, treated with antibiotic and salbutamol but with poor response. Past medical history: not HIV exposed, no epileptic, asthma, or TB. Socioeconomic status: the child is second born in a family of 3, both parents are alive and not in formal employment, actually not able to afford 3 meals a day. On examination, vitals was 7.0 kg, temperature 39.1, respiratory rate was 88, with a pulse rate of 120 and a Z-score of -1, a mark of 12.4 centimeters. Ill looking in his plateau distress, febrile pale, not cyanized. Features of Down syndrome was noted, among others, low set eyes. So there was chest in drawing, its general cause cryptation, S1 and S2 on auscultation was not tachycardic. Abdominal examination was normal. So the child was admitted with sepsis, pneumonia, acute gastroenteritis with moderate malnutrition in child with Down syndrome. So those were tests being done on the 2nd of March on admission. HB was low at 8.3 grams per deciliter. The white cell count was elevated at 14.4 with elevated platelet at 645. The COVID was tested. COVID test was done, it was negative. HIV test was negative. Gene expert was negative. And urine lamp was positive. Client was treated with ceftriaxone, paracetamol, and plumpinate with a folic acid and piriton. And client was initiated on ATT. We have 3 questions for the panel. Question 1, how can we enhance TB case identification and early treatment initiation at our facility? Question 2, how would we know if this was or is a case of DRTB since the stool MTB leaf expert was not detected by LAM or was positive? Last question, do we need to conduct contact tracing in this case, considering there is no history of household TB contact? Thank you.
Thank you so much, Jackson, for taking us through this case. And it's actually a very interesting case with very good learning points regarding the subject that we have discussed, plus a few more things that involve tuberculosis. So I'll just, a brief overview, we're dealing with a 1 year, 2 month-old baby from Sesheke who's neither HIV exposed, nor neither did they also have a gene expert positive for tuberculosis. However, a diagnosis was made on use of urine lamp after noticing that this child was having features of failure to thrive. And this is also a child that the team thinks has Down syndrome based on some of the physical signs that were noted on examination. Of note, this is a child with a weight of 7 kgs and was noted to have a temperature of 39 degrees Celsius. And the anthropometric measures, she was at -1 Z-score. And the mid-upper arm circumference was at 12.4 centimeters. So at this point, allow me to open it up to the network. If you have clarifications on this child, or if you'd like to ask Team Yeta anything regarding this case. Dear network. So I see already in the chat, there are some questions that are very interesting. There's one coming in from, is it Chilufia, who asked to say, can urine lamp be used during ICF? I suppose that was supposed to be ACF, especially for contacts to bacteriologically confirmed. That's a very, very important question. We will have some of the subject matter experts respond to that. And I can see there's a comment in the chat from Dr. Mopeta saying the quality of the sample collection is threefold. 1, at point of collection, 2, at transportation, 3, at the level of the lab. We normally emphasize point 1 and 2. We normally emphasize point 1 and forget point 2 and 3, which is very, very important. All of us have a role to play in the quality of the sputum. Are there any questions, clarifications on the case? All right, I see there are 2 hands. There's one from Kajima, Western Province in Monde, and then we have Teddy Ntaulo. We'll start with Kajima in Western Province. Please go ahead with your question or comment.
Good afternoon, team. I wanted to find out the vaccination record of this child. Is this child up to date vaccinated? I think I didn't get that information in the history. Thank you.
Thank you so much. Is the vaccination history, Team Yeta. Before you answer, Teddy Ntaulo.
Yes, Dr. Singini. Though the first one has been covered by my colleague from Western, but the second one that I have is I wanted also to hear the maternal history of the mother of this child. Were any serious illness when she was pregnant? Was she treated for any severe illness then?
Right, thank you so much. So we have those 2 questions that have come through. I see a hand from Vines Mpungwe. Please ask your question, then we throw it back to Team Yeta to address the concerns. Vines?
Thank you. The patient was sick and had visited several facilities before it came to Yeta Hospital, which means there is maybe more information which could have been missed. But the third question, which is saying, do we need to conduct contact tracing in this case, considering there is no history of household TB contacts? This is where we are making a lot of mistakes as health workers, because we are believing a lot of what the patient is saying. We are readily believing what they are saying. We need to ask more questions to find out about TB contacts. After teaching them about TB, they should know TB, and then we should even visit, because as long as the child is sick, the contact must be there.
Thank you so much, Vines, for emphasizing the need to get a complete history and also pursuing information, as was discussed, actively seeking TB. So one way of actively seeking TB is actually asking about the family history of TB from where the patient is coming from. So back to Team Yeta, there are 2 questions. Just elaborate on the vaccination record on this child, and also a question that came through from Ted Ntaulo was asking, so what's the maternal history for this child? Like to know if there's any background of serious illnesses in the mother while she was expecting. Jackson?
So thank you. My vaccination history, the immunization was up to date. There was no significant maternal illness noted on history. Then I saw something on the chat about F75. We saw it's out of stock, as well as the F100. The child was just given a Plumpinut. Thank you.
Thank you so much for that feedback. There's also a question asking about the cardiac examination finding in this child. So that question is coming through from Dr. Chemika Piri. Would you like to speak to that?
Nothing much was not on the cardiac examination. S1, S2, however, was tachycardic.
Thank you so much. Our main hub computer has had a lapse in connectivity, so I'll continue on this one. So there's a question that came through saying, asking about the feeds that this child was given. I think Team Yeta has mentioned that they had a shortage of rather F75, hence they gave what was available. And then there was a question on the cardiac findings. Team Yeta, would you like to address that?
Yes, Doc. Nothing much was significant on the cardiac finding, but S1 and S2 was cardiac.
All right. So the only significant finding was that the heart rate was elevated. Right. Thank you so much. Are there any questions, additional questions to Team Yeta before I start throwing out the questions to the subject matter experts? All right. We apologize for that lapse in the connectivity. As we were asking to say, is there any additional question or clarification to the team from Yeta regarding this case? All right, I see none. Dr. Mpeta, there's an interesting question in the chat about the use of urine lamp when doing contact tracing. Would you like to speak to that?
Thank you very much, Doc. I hope my my voice and audio is quite clear. Yeah, so I noted that Dr. Mwinga ably actually addressed that, saying that urine lamp should be used on the categorized patient, which is very important. So once we are doing contact tracing, we have to remember two aspects about contact tracing. There's contact tracing, of course, which is done in the clinical setting, and there's also contact tracing, which is done in the public health context, of which most of us normally look at the public health context. This is looking for persons who are well, who must have come across, somebody who has, bacteriologically confirmed TB, which is good. And we know that this is important and we need to do it. But the other contact tracing that we should emphasize, and mostly that is missed, is done in the clinical context. You see, there are so many patients that we diagnosed of TB on the ward or in the clinical setting, but we do not actually attempt to look for TB in all those patients that are sharing the wards or, the ward spaces with these patients. So it's something that should also be emphasized. So I would suggest that actually urine lamp would be appropriate for contact tracing in the clinical setting, because most of the patients would actually meet the clinical criteria for urine TB. That is, most of them will be immunocompromised. Most of them will come in very sick, especially in the admission ward. Most of them will come with a high temperature. Most of them will have symptoms and signs of sepsis, including laboratory markers. So it is very, very cardinal that we enhance contact tracing in the clinical context, which has largely been ignored, even by experienced clinicians like myself. So I think that was my different.
Thank you so much, Dr. Mpeta, for that valuable contribution. And I see there's two more questions, two questions for Team Yeta, and then we will start looking at the questions that Yeta has raised. There's one asking for the chest X-ray. Was the chest X-ray done for this child? This is coming from Akayo Mbokwa. And then we also have a question from Peter Singogo in Ndola, who's asking, this child weighing 7 kg and had a MUAC of 12.4. Was this child edematous? Team Yeta?
No, there was no edema.
All right. And then regarding the chest X-ray?
So for chest X-ray, we didn't do it. We had no fumes.
All right, thank you for that feedback. I see there's a hand from Dr. Mwinga. Please go ahead, Dr. Mwinga, with your comment.
Thank you, Chair, and thanks, Team Yeta, for the presentation. It's indeed good to note that despite the strides that we've made as a country with the TB notifications, for the pediatrics, we've not yet met that target. The PEDS should contribute about maybe 10 to 15% of all notifications that we get per year. But for the children, there are still lapses, and I think it all borders mainly on the provider. And it's good that Dr. Muyoyeta actually brought out the issue of TB screening at all service delivery points, be it MCH, malnutrition. And for the pediatrics, we've also come up with now the use of child-friendly specimen. You know, we can still do a gastrovag, better yield, but then we can also still do stool for expert. And the utilization of stool as a sample really for TB diagnosis amongst the peds has not been very widely applied or utilized. So maybe these are opportunities that we have, low-hanging fruits indeed for everyone, where we have similar conditions like these to look at using stool as a sample for and expert for TB diagnosis. Over.
Thank you so much, Dr. Mwinga, for highlighting that, especially the need to do expert on stool, which we must commend Team Yeta that they actually did think of doing a stool expert, even though it was negative in this particular case. So well done, Team Yeta, for thinking stool as an alternative sample for expert. So as I can see, there are several hands and comments popping up. We can see there are some comments from Mudenda, who is really highlighting the considerations to put in when you want to use LAM. And I can see we also have Nancy Chanda has also highlighted the guidelines for use of LAM, who to test. And like, I invite everyone to take a look at the chat box as I invite the team from Yeta to reshare their screen so that we can look at the questions that they have and get the expert opinions. So the first question that came from Team Yeta was, how can we enhance TB case detection and early treatment at our facility? So I'd like to invite Dr. Mwinga to briefly speak to the first question about how they can enhance case identification at their facility.
Yeah, so thank you very much. So indeed, I'm getting some feedback. So how do they enhance?
Sorry, Dr. Mwinga, I just want to remind the network to keep their microphones muted when you're not on the floor. Please go ahead, Doc. Dr. Mwinga, please, you may go ahead with your submission.
Yeah, thank you, Chair. I could not unmute. The host had disabled that function. Yeah, so like I had earlier mentioned, to enhance TB case detection and early treatment at facility level, it's multi-pronged. It actually starts from the providers themselves, and more so in children. Remember, in children, the TB presentation might not be as classical as we would see it in adults, where there's usually evidence of that cough, night sweats, drenching night sweats, weight loss. In children, sometimes it's merely failure to they may have failure to thrive.
No. I wanted.
Yeah, so the symptomatology or the presentation in children might be slightly different from that in adults. So on the healthcare provider, I think it's the clinicians there, first of all, with a very high index of suspicion. And remember, for these, like this child who had self-selected with malnutrition, for this one, you actually go flat out to actually do the investigations, even without the child meeting all the the symptomatology, but by virtue of this child being severely malnourished, was already a high-risk child. So for this one, really is the high index of suspicion on the providers. And then, of course, they go on to do the targeted investigations. So we've mentioned these two. We've mentioned urine lamb. Where the expertise is there, they could also do a gastric lavage. You know, gastric lavage, the yield is slightly better. So for a child that's below the age that can expectorate, would actually recommend that a lavage is also done if the expertise is there at the facility. And then there are other investigations, ancillary investigations that will be part of the screening now, and they are part of the investigations. Issues like chest X-ray. So an X-ray becomes very cardinal under the circumstance. And for this one, probably if an X-ray was done and was highly suggestive, of course, we marry it with a proper history of probably domestic TB exposure. You would actually start the treatment even on clinical grounds without having detected the TB in any of the samples that had been collected. But we always want to be labor to make sure that we confirm the TB that we are treating. So we can use the array of the investigations that are available to us, starting with these two, urine lamb. If it's a child who can cough, you can also do the sputum, or if not, you can do the gastric lavage. And of course, you do the X-rays as well as ancillary. That would actually point towards helping you make a clinical diagnosis if need be.
Right,
and,
thank you.
And I know on the call, we also have a pediatrician. We will have Dr. Piri, maybe he can chime in and say one or two things. Over.
Thank you so much, Dr. Mwinga. Dr. Piri, any thoughts, or maybe Dr. Kozia Ziambo, just to add on? All right. Dear network, as we are getting deeper and deeper into the discussion, and we should be wrapping up in the next 10 minutes or so, I'd like us to also answer some of the other questions, and then we'll carry on with any additional ad hoc subjects. So the question: how would we know if this case was or is a case of drug-resistant TB, considering that the MTB reef expert was not detected and the diagnosis was based on lamb? Dr. Nancy Chanda, would you like to speak to that?
Thank you, Dr. Singini, and good afternoon, everyone. Yeah, so of course, I agree with the previous speaker, Dr. Mwinga, that we need to do all the array of tests just so that we increase our diagnostic capabilities. I am aware that the stool expert was negative. So the lamb is the only thing that we have. So lamb does not test for rifampicin resistance. So obviously we cannot tell from this test alone. If we did a stool, then we could know. And one other thing in a child like this is to look at the primary, the index patient. So contact tracing again is very important. So we need to find the primary case and find out what type of TB did they have. So if, for example, this child's made, because we know that children, can catch it from anyone in the household, even if it's not the parents, because somehow it seems like the parents were healthy, but we need to ask about everyone else in the household. Could it be the maid? Could it be somebody else that lives in the home? And we need to find out what type of TB that they have. So if the primary case has got DRTB, we need to treat this child as DRTB. And I think another thing that we probably could do is repeat the test. If we feel that maybe there was a way, we've heard from the lab, one, that sometimes specimens are not not of good quality. So if that's a suspicion that the specimen of the quality was not okay, the quality of the specimen was not okay, then that's another thing that could be done to repeat the expert test. so that we could get a rifampicin resistance result. Thanks, over.
Thank you so much, Dr. Nancy Chanda, for really highlighting the importance of using molecular tests like expert to confirm if there's rifampicin resistance or not. And then I know you briefly spoke to question 3, which is talking about contact tracing in this case. So allow me to throw this question at Dr. Muyoyeta regarding contact tracing, where there's no considerable history of TB rather contact with TB from the household. Dr. Muyoyeta, should we do contact tracing in this case?
Yes, we should, and we call it reverse contact tracing in this instance. So yes, sometimes the parents or the caregiver may not give full information at the time that the child is being evaluated for TB. But, a visit, and I think this has been emphasized already, a visit to the home and further probing may actually, give some information as to where this child could have been infected. There isn't much time, but I don't know if I'm allowed to share briefly a case of a child at one of the health facilities where we were doing childhood TB case finding. So this child presented to the facility, was not too ill, did not have classical symptoms or signs of TB, but had some. And so, the debate was, should this child be diagnosed with TB or not? The chest X-ray showed mild lymphadenopathy. So what was interesting, so further evaluation and probing, it turned out that the mother had actually previously been treated for TB like a year before. And in fact, I think, I forget the details, but actually how the mother was found or why they asked, I think the decision was made to start treatment, but the doctor who was seeing the child immediately started the reverse contact tracing and started with the mother. And when they did a chest X-ray on the mother, the chest X-ray was quite bad. And so when they probed further, the mother then reported and said, oh, I was treated for TB a year ago, and she obviously had sequelae of TB, but this information hadn't come out immediately when the child was being evaluated. So yes, contact tracing must.
Right, thank you so much, Dr. Muyoyeta. And just to draw your attention to the screen, really speaking to the guidelines for the use of LAMP. And this was a submission from Dr. Nancy Chanda, who shared that response in the chat. So at this juncture, allow me to just invite Dr. Muyoyeta to wrap up this session with the punchlines about active case finding, and we will call it a day. Dr. Muyoyeta, last remarks?
Thank you so much. So colleagues, fellow practitioners, in the absence of an effective, highly effective vaccine, what we have currently is active case finding. And this is a global priority, actually. If you go to the WHO guidelines, the Stop TB Partnership guidelines, what they're putting forward at the moment is that, we should prioritize active case finding. So it is important that we prioritize this active case finding. We have learned today. I saw a question where somebody asked and said, but are facilities being, oriented on this? I will say yes. I think it depends on where you are, but definitely I know that in Lusaka and in Southern Province, we've done quite a lot of, disseminating the active case finding and activating facilities for active case finding. I think, and then we must all be involved. I noted the question from, I forget the name of the doctor from Kabwe, that, TB corner and clinicians not being involved. Yes, generally clinicians, we are not that heavily involved in TB. The ask is that we must be heavily involved in TB. It's not just at diagnosis, but it's even throughout the treatment and monitoring of those patients during treatment that we must give support to the nurses who are largely the ones manning the TB, the chest clinics or TB corners, as you would like to call them. Thank you very much.
Thank you so much, Dr. Muyoyeta, and I'd also like to particularly thank the subject matter experts that have helped us in today's case, notable among them, Dr. Francis Mpeta, and we also have Dr. Linos Mwinga from CDC Zambia, and then we'd also like to commend Dr. Nancy Chanda Kasese from USAID Zambia for having taken time to address some of the questions regarding TB active case finding. And a special gratitude goes to Dr. Muyoyeta for taking us through the presentation. And you can note from the chat box that there's been a number of commendations about how good the presentation has been. So I also would like to thank the entire network for having taken time to take part in today's echo session. And also a huge thank you to Team Yeta for taking part in today's echo session and for that brilliant case with very, very valuable learning points. I'd like to thank our team from IT for making this possible and coordinating today's session so seamlessly. We really thank you for your support. And I see there was a comment regarding transitioning patients from first line to TLD. I think we can have that discussion in the subsequent echo session, and we'll discuss this on our virtual platforms. Otherwise, thank you so much, everyone. We are signing out.